Hello everyone, my name is V. I'm an undergraduate student studying biology, and today I'll be going over accelerated wound regeneration through pulse-negative pressure therapy, or NPWT, and how we can leverage this technique to provide insights on immune modulation for clinical applications. Wound healing is a highly regulated process involving cellular interactions that collectively restores tissue integrity following an injury. Beyond just simple lesion closure, clinicians actively seek for therapeutic approaches that not only promote rapid tissue repair and regeneration, but also reduces scarring and risk of infection. In the study, we provide evidence that pulse-negative pressure wound therapy not only expedites reepithelialization and tissue remodeling, but also improves the overall quality of wound recovery in a clinically relevant preclinical model. For this experiment, 6 male New Zealand white rabbits were acquired. The rabbits were housed under identical conditions of diet, light, environment, with housing temperatures maintained at 20 to 25 degrees Celsius. Male animals of similar age and weight were selected to account for the influence that sex hormones and age would have on wound healing and to ensure the uniformity of drug dosing. For the surgical procedure, the rabbits were first administered with enrofloxacin, an antibiotic, 1 day prior to the surgery to treat any bacterial infections that may be present. On the day of surgery, anesthesia was induced intramuscularly with xylazine, a painkiller, followed by diazepam, which is a muscle relaxant and anxiety reducer, then overall maintained with ketamine, which is just another painkiller that has longer-lasting effects. Once adequate anesthesia was confirmed, 2 dorsal incisions were created per animal, 1 on each side of the spinal column. 1 incision served as the untreated control, while the other served as the experimental wound. Negative pressure therapy was then initiated 24 hours post-surgery and applied at negative 0.13 bar in cycles of 5-minute suction followed by 10 minutes of rest for 4 hours daily the first 3 consecutive days. Afterwards, the therapy is stopped and the wounds are observed over a 21-day period. For histopathological evaluation, tissue samples were collected on days 1, 3, 5, 7, 14, and 21 by mounting them to a paraffin-embedded piece of plastic, then stained using standard protocols. Finally, the slides were assessed for granulation tissue formation, epithelialization, cellular infiltration, and vascularization, then compared with one another. For evaluation, 2 primary histometric parameters were assessed as markers of healing, the first one being approximation, or A, defined as the depth of healing from the fascia to the epithelium, and the second one being gap, defined as the distance between the wound edges, or G. Our findings indicate that the A parameter, deep tissue healing, was consistently greater in therapy-treated wounds compared to the control. As we can see, the depth of the wound was filled with granulation tissue and continues to heal upwards to the epithelium as time goes on. However, in the control wounds, the depth is filled with connective tissue, which takes longer to heal and is what causes the scarring. On the other hand, when looking at the G parameter, or wound edge distance, this revealed a slightly different pattern compared to the depth of healing. The histology slide showed that negative pressure therapy initially increased wound edge separation during active suction, which is days 1 through 3, likely due to the mechanical traction at the wound surface. However, after discontinuation of the therapy, wound edge closure accelerated as seen on day 5, and by day 7 onwards, the treated wounds demonstrated a significantly smaller gap distance compared to the control. By day 21, the wound edges for both the experimental and control groups were completely closed. However, the tissue in the treated wound had a much better architecture and reepithelialization. In conclusion, this dual effect suggests that while negative pressure wound therapy may appear to delay superficial closure, it ultimately promotes faster and more robust dermal repair. Our findings also support intermittent rather than continuous application of negative pressure wound therapy as the more effective approach. Although our study supports its efficacy in an experimental rabbit model, translation to clinical practice requires careful attention to treatment protocols, pressure parameters, and patient selection. For instance, negative pressure wound therapy can be especially beneficial for individuals who are at a higher risk of delayed or have complicated wound healing. Looking into the future, we can examine wound exudate and cellular activity under negative pressure wound therapy to advance our understanding of immune mechanisms driving tissue repair, enabling for more data-informed and personalized wound care. Thank you for listening.